What we really have done in the last 15 to 20 years is recognize there's a diversity in breast cancer that we didn't previously understand. We tended to treat the disease as one disease, a malignancy that arose in the breast. And we, as I've said in the past, should have known, given the different outcomes for patients that were treated by the same approach, that we weren't dealing with one disease. But it was pretty remarkable that it took us a long time to recognize that that was a reality. It wasn't good luck, good doctor, bad doctor, but it really was different diseases we were dealing with. If you've never looked at breast cancer under the microscope, it doesn't matter because you can see right here, these are all 8 breast cancers from 8 different patients, and they look quite differently. But they're all breast cancers. 7 of the 8 are invasive. And what we've had as our main tool over the last multiple decades has been what the pathologist can describe when they look under the microscope. So they can tell us whether it's in situ or invasive, whether all of the, quote, malignant cells are restricted to the ducts. Many people call that precancer, but there's no invasion. And as you've just heard from Sue, many of those tumors never go on to invade. And we are appreciating that that's not just the case with breast cancer, but other malignancies may be similar in terms of how they behave. Whether or not it's well differentiated or poorly differentiated, whether the tumor itself remembers what it was supposed to be, and the tumor cells, while they're invading, still try to form glands, as you can see in the upper panel, still trying to form circles, or whether they are so far gone from what they used to be that they don't remember anything, and they're just wildly dispersed throughout the tissue, or poorly differentiated tumor. The nuclear grade, the size of it, whether or not the nucleoli are prominent, et cetera, are things that the pathologists have been able to tell us, from low grade looking more like normal nuclei to a high grade looking less like normal nuclei. What the margins look like, and what the different cell components of the tissue are, including lymphocytic infiltration. As both Sylvia pointed out and Sue pointed out, we are coming to an increasing appreciation that the immune component of these diseases, not just breast cancer, but many malignant diseases, is critical. It sort of was intuitive for a while, but that field has been snagged with a lack of progress for many malignancies, cervical being a notable exception to that in terms of developing vaccines and immune-based therapy. But now with our ability to better manipulate the immune system, we can actually harness some of these, and you've heard about some of the new drugs that are being tested in melanoma and lung cancer that I am certain will be moving forward in breast cancer as well. But the question is, with the new molecular information, can we decipher the genetic information, the molecular genetic information, and explain this diversity? So the global burden, I don't need to educate this group. You can lecture me in terms of the burden. These are old statistics. It's up actually a little higher now, about 1.6 million new cases globally each year. Interesting, though, is in the World Health Organization statistics, 1 in 10 of all cancers reported are breast cancers. Now, in part, that's alarming, but it's in part due to good news in the sense that women are living longer in developing countries due to progress in sanitation, water supply, perinatal care, so women aren't losing their lives in childbirth, living longer, a greater risk of breast cancer. Again, you all know this. More than 600,000 deaths globally a year now, and you know the U.S. statistics very well. Now, the past, as I've said, has been dominated by a one-size-fits-all approach. You had breast cancer, you got one of a couple of approaches we had. It almost always included surgery, attempting to remove all of the primary tumor. There was additional radiation to sterilize the bed and try and keep that area clean. And then came chemotherapy for patients that were, quote, at high risk, as best as we could determine who was at high risk. This is a graph that all of you have seen, I think, in the past, that is from a landmark study that was done by some investigators in the Netherlands, where they had a cache of tumors in the freezer from women who were operated on prior to Gianni Bonadonna identifying adjuvant chemotherapy as something that could make an impact. So these women were only treated with surgery, and some of them got additional radiation, but they got nothing else. They got no hormonal therapy. They got no chemotherapy. And then they were followed, and the outcome data were all annotated into these cases. And then molecular analysis that later became available was applied to those tumors when they were removed out of the freezer. And you could see that the disease broke itself down into 4 subgroups. The so-called luminal A, the dark blue line, highly ER/PR positive, the luminal B, the lighter blue line, still ER/PR positive, but other alterations in the hormone receptor pathways. And the outcome data for those patients was not as good. The red line is the triple negatives. They are defined by what they don't have, not because we know what they do have. They don't have high levels of hormone receptor expression, and they don't contain the HER2 alteration. And the purple line is the HER2 alteration itself, and those women who have that disease. And those 2 latter lines are among the worst in terms of how they behave clinically with regards to the tumor using the old approaches. So we now appreciate that all cancer is genetic. That is not to say all cancer is inherited. In fact, only a minority are inherited, only between 10 and 15%, as best we know today. But all cancer has at its basis alterations in genes that regulate the control of growth and differentiation, motility, and critical pathways. And we all acquire mutations over time, every time a cell divides. We have, again, as you heard me say in the past, we have spell checkers, thankfully, in our cells that will look at the DNA, look at the blueprint, and if there are mistakes that have been made, they can identify those mistakes, cut them out, and repair them. And these DNA repair enzymes and pathways are numerable. That's the good news. The bad news is they get less efficient over time. You're on warranty till about age 35. After that, you're off warranty. So I'm long past warranty myself. That is not to say they go away after age 35. They say they get less efficient. And nature has seen fit to put them in place long enough for us to replicate the species, and then you're off warranty. So you can do things to accelerate mutation, radiation exposure, alcohol, chemical carcinogens, cigarette smoking, etc. But even if you lived a perfect life, ate everything the right way, did all your exercises, did everything you're supposed to do, every time a cell divides, a mistake can be made in copying that blueprint. And if it's in critical genes that govern critical growth pathways, you can be off to the races. We now say there are 12 different molecular classifications for breast cancer. You saw from Sylvia some of the TCGA data. And it's true we've gotten very good at dividing, subdividing, and subdividing even further by molecular biology this disease. But the reality is after we've done all these subdivisions, the disease still breaks itself out into 3 therapeutic categories. Those that are hormone receptor positive, those that are HER2 positive, and those that are triple negative. Again, Sue gave you a beautiful statement about what happens with triple negative disease. We all assume, or at least the public generally assumes, that it is uniformly a terrible disease to have. None of these diseases are good diseases to have. However, a diagnosis of triple negative disease doesn't always mean that things are going to end up with a lethal outcome. In fact, about 40 to 45% of patients with triple negative breast cancer will do well long term with traditional cytotoxic therapy. However, it's the 55 to 60% who recur quickly and whose tumors march through everything we have that make the whole group look bad, and we don't know how to separate the two as yet. The HER2 group is marked by the HER2 alteration, and the large group, the largest part of breast cancer, are the ER-positive breast cancers. Now, the HER2 alteration is something that you've heard of, we've talked about in the past. It's about 20 to 25% of breast cancers. We can identify it with simple tests when it's present, and we can see that the women who have this subtype of disease, as you saw in that earlier graph, have a worse outcome. Can we make a difference on that? Well, this is the earliest data, and this is the animal data. We had cell line data even before the animal data that an antibody directed against a receptor could reverse it. That's the drug you know as Herceptin, or trastuzumab, could shrink or stop the growth of tumors in mice, whereas the gray line is the tumors treated with a control antibody. Can we make this impact happen in patients? And the answer is yes. Again, you all know these data. If you remember this purple line from the Netherlands chart and some of the data we did prior to the molecular analysis globally, you can see in another variation of the curve that you saw from Sue, something that was prepared by my colleague Carlos Barrios, who looked at the sort of history of breast cancer with the different therapeutic interventions. And it's a pretty interesting chart in terms of seeing what the outcomes have been. This is what the outcome has been when we only had surgery. This is prior to Bonadonna's idea of adjuvant chemotherapy. And so we lost a large number of patients that were treated with just surgery alone. But as Sue pointed out, many of them probably, of the long-term survivors, never needed surgery to begin with, and were going to have a good outcome. This is what adjuvant chemotherapy added from CMF, the Bonadonna studies. So it did make an impact of about 6 to 8%. When we added anthracyclines, that added about another 3.5 to 4%, but it added some new problems that we hadn't seen before that you've heard about. This is what the taxanes did. So as a single chemotherapeutic entity, the taxanes have probably made the biggest impact in terms of breast cancer outcome, looking at 20-year data. When you do different sequences of it, dose dense, et cetera, you can get variations on the theme. But if you now take the disease not as one disease and by subclass, if you remember that group that were the HER2 positive that had among the worst outcomes, and you treat them with the drug trastuzumab, this is now the outcome. They have gone from becoming the worst in terms of outcome data to among the best just by the addition of trastuzumab to standard therapeutic regimens. Now, still, we don't do well for all patients with this disease with trastuzumab. We lose patients even though they have the alteration and we're using the drug correctly. So what's that all about? Well, that's where the field is at now. The new drug that's just been approved for this space is TDM1. It is a very effective drug. We are pushing to have it looked at without, as you all are, in terms of some of your advocacy positions, to have it used without additional systemic chemotherapy. And there's a trial that will be led by TRIO that your leadership is involved in designing that will not have chemotherapy as one of the arms. Here are the outcome data with TDM1 versus traditional trastuzumab in women whose tumors have recurred after we've given them trastuzumab. And if we give them a different trastuzumab regimen with chemotherapy, the yellow line is on the bottom. TDM1 alone is the purple line on the top, so it can make a big impact. Now we'll see what happens in the neoadjuvant setting. The biggest piece of this pie, the hormone receptor, I'll end here. Remember, you heard that a lot of patients with this subtype do reasonably well long-term, but again, as you heard from one of the prior lecturers, patients still will have recurrences very far out, and we know there are many recurrences out. Early on, if I can, well, that doesn't show up too well, but in this dark blue line, the first part of the curve, there are a number of tumors that recur quite quickly and cause problems. In the lighter blue line, there's even more of those, and the long-term no problem becomes a smaller number. And this is a big piece of that breast cancer pie therapeutically. Can we do better there? All of that we've done in the last 4 decades has been an assault on the hormone receptor pathway, using AIs, using tamoxifen, and it has made an impact. SERMs, aromatase inhibitors, or pure anti-estrogens. But can we do better? Now, the newest therapeutic, we're asking where we are today, the newest therapeutic approval has come for everolimus, or Afinitor. Sylvia's talked about it, Sue's talked about it. It is a drug that has made a difference. I'm now taking the investigator's call of the data, which is giving it the best available spin on it, going from 4.1 months with best available standard therapy, the aromatase inhibitor, to 10.6 months. So it's not just a few weeks, it's a reasonable improvement, but still nothing we want, and it comes at a reasonably high cost. I think the side effects have been downplayed. I think the mucositis, I think the asthenia, I think the pneumonitis is more of a problem than we previously recognized. So, so in English, The asthenia is just profound fatigue. The pneumonitis is actual inflammation in the lung that we don't know quite what that's, and some of it can result in longer-term pulmonary problems. And the mucositis is basically something that there's severe ulceration along the mucous membranes, in particular in the mouth and the throat. It is transient. Most patients recover relatively quickly, but when it does occur, it can be quite severe and cause a lot of problems. We looked at another drug, and I'll end on this, that you've just heard about recently, that again, your leadership has been involved in helping design and look over some of the trials here, is a drug that is a CDK4/6 inhibitor. This is an enzyme that plays a critical role in the cell cycle. We put it through some DoD funding we got through testing in breast cancer, and a breast cancer panel that represents the spectrum of the disease. And we found that it broke itself out into 3 groups. To the far right, the bigger the bar is, the worse the cells respond to the drug. The smaller the bar is, the better the cells respond. And you can see there's a resistant group, an intermediately sensitive group, an extremely sensitive group. And we look at what the subtype was. This became in blue the ER-positive luminal breast cancers, the one that we are trying to find something new for beyond hormone receptor intervention. And so we did a study from phase 1 showing it was safe to add this drug, with the only side effect being a transient decrease in white count, never requiring growth factor, never resulting in febrile neutropenia or causing infections, and always recovering. And we randomized patients to receive best available standard therapy versus the addition of this drug. And we found that there was an improvement in patients that were responding, and with the best available AI therapy, there are more patients coming off study because of progression than when they got the new drug. But the real shock came when we looked at the progression data. The PFS data showed this. There was a dramatic improvement, not just in a few months, but a significant improvement. In the first look at the data, this went from about 5.5 months to 18 months. There were more data and more patients enrolled, so a larger number, now a total of 165 randomized patients in phase 2 type studies in a part 2 part of this, and the combined analysis shows this. And this became very exciting. When we saw it, we've gone from, with the best available standard therapy, from a median progression-free survival of 7.5 months out to 26 months, or 2 years. And you are all graduates of Project LEAD. You know how to read these charts. The median has been reached for the control arm, but the median has not been reached yet at 26.1 months in the experimental arm. So we're very excited about these data. That's moving forward to full phase 3 testing. So this is where we're at with that. We hope will make a larger impact in the hormone receptor positive group, and we're working feverishly on trying to do something better with triple negative disease to identify those patients who do benefit and develop better and less toxic therapy for those who don't, as well as the other 3 subgroups. So I think the future is not perfect by any means, but I think it's much better than it was when the only approach we had for this disease was surgery and radiation and just systemic chemotherapy, hoping that we had better outcomes. Hopefully I've convinced you of that your work, your efforts, everything you've done, never let us off the hook, always demand more, but it has had an impact, and we'll continue to work at it to make even more impact. Thank you.